Welcome. I'm Carolyn Ldct, founder and CEO of the Prevent Cancer Foundation. It's my pleasure to open the proceedings and thank you for joining us for the 2021 Prevent Cancer Dialogue. Though we never could have imagined that the continuing pandemic would require a second year of a virtual format, we've worked hard to ensure that it truly remains a dialogue. And we hope you will take advantage of all the ways you are able to interact with the speakers and panelists, as well as your colleagues from across the nation and around the world. As with our in-person dialogues, our hope is that you will log off with fresh ideas and perspectives that you can implement into your work. Before we begin, I'd like to acknowledge the generous support of our gold sponsors, without which this event would not be possible. Special thanks to Grail and to Exact Sciences. This event would also not be possible without the tremendous effort of the Dialogue Planning Committee, led by our own Jody Hoyos. Jody has been our Executive Vice President for 2.5 years, but as of April 1st, she became our President and Chief Operating Officer. Congratulations, Jody. Jody worked hand in glove with Vice President of Programs, Dr. Karen Peterson. And I want to add special thanks to Adrienne Harkness, Senior Manager of Community Education and Conference Planning, and to the entire Foundation staff. This year's dialogue explores the dual themes of innovation and health equity. We'll explore these topics within the framework of cancer prevention and early detection over the course of 3 webcasts. Some of the key upcoming conversations include challenges and opportunities in primary prevention, the impact of COVID-19 on public health efforts, and genetics and genomics in public health. As the finale on June 2nd, we'll wrap up the 2021 dialogue with our cancer prevention laurels. We'll be presenting awards honoring 3 individuals who spent their careers saving lives through cancer prevention and early detection. Throughout the dialogue, I invite you to take time to learn more about the Prevent Cancer Foundation and our many programs and education initiatives. We stood up one of those education initiatives in response to the pandemic and the unprecedented number of cancellations of appointments for physical exams, screening tests, and vaccinations. You may have seen this public service campaign back on the books, covered by media as varied as USA Today, the Wall Street Journal, and national and local TV outlets. The message is clear: screening saves lives, and you are more likely to die of an undiagnosed or late-stage cancer than you are of COVID-19. But what about the future? To celebrate the Foundation's 35 years of saving lives through cancer prevention and early detection, we set bold goals that we are focusing on for the next 15 years, leading to our 50th anniversary. In order to meet the challenge of reducing cancer deaths by 40% by 2035, we are committed to investing $20 million into innovative technologies to detect cancer early and advance multi-cancer screening, $10 million to expand cancer screening and vaccination access to medically underserved communities, and $10 million to educate the public about screening and vaccination options. We dare to imagine a world where no one dies of cancer. For more information, please visit us at preventcancer.org or find us on social media.
I would like to begin with some introductions to the speakers that you're going to be hearing today. Our first speaker will be Ophira Ginsberg. Dr. Ginsberg is a medical oncologist and the director of the High-Risk Cancer Genetics Program at the Peterwright Cancer Center at the New York University. And she's associate professor in the section on global health, the Department of Population Health at New York University Grossman School of Medicine. Ophira is a leading cancer researcher in women's global health with nearly 20 years of experience in cancer prevention and control. Our next speaker will be Dr. Daniel Peterwright. He is a radiation oncologist in Rapid City, South Dakota, and is the PI of the Walking Forward Cancer Disparity Program, which has been funded by the NCI since 2002, and you'll hear about that today. He has also received national recognition for his expertise in brachytherapy, cancer disparities, and clinical trials, and especially for his work with the Northern Plains Indians through patient navigation, clinical trial access, and identification of barriers to early detection and successful treatment. The third speaker is Dr. Gloria Coronado. She is an epidemiologist and the Mitch Greenlick Endowed Distinguished Professor in Health Disparities Research at Kaiser Permanente Center for Health Research. She has done very valuable work that inspires health systems to make sensible, evidence-based decisions to successfully engage hard-to-reach populations in life-saving preventive behaviors. She, over the course of her career, Dr. Coronado has served as a PI or co-PI on over 35 federally funded grants and co-authored over 180 peer-reviewed manuscripts. Our speakers' bios are in your materials. They're much lengthier than what I've told you right here, and I would encourage you all to read them. They truly are outstanding. We will wait to address any questions and answers that you have until the end of the three presentations, and you can ask questions and comments by clicking on the Q&A icon in the bottom right of your screen. I encourage you all to take notes, formulate your questions. We will have a short period of time after the presentations for discussion, and we'd like to take as many of these as we possibly can. So let's get started with our first presentation from Ophira Ginsburg, and who will be followed by Daniel Peterwright and then Gloria Coronado. Ophira?
Thanks so much to the Prevent Cancer Foundation for the invitation to speak today. I'm Dr. Ophira Ginsburg. I'm based at NYU Grossman School of Medicine, and I'm going to speak about the elimination of cervical cancer. How do we get there? I have no financial relationships to disclose. In the first slide, I want to draw your attention to recent data published in 2020 from 2018 estimates of the age standardized incidence rates for cancer among women. I just want to note here that we're talking about biological sex here, but in fact, the information I'm giving today, I hope, is seen as being very inclusive of all genders, anyone who's at risk for cervical cancer. So this first slide looks pretty pink, doesn't it? And pink is associated in the slide from IARC, the World Health Organization's Cancer Research Agency, with breast cancer. And you can see that in 156 countries, breast cancer is the top cancer among women in terms of incidence. But the second most common in 27 countries is cervical cancer. Now that's something to keep note of for the rest of the talk. Cervical cancer remains the #1 cancer among women in 27 countries, despite being entirely preventable. You can see here most of the countries, but not all, are in sub-Saharan Africa. Here we see Bangladesh, and here we're in South America as well. In the next slide, I'm going to show you mortality data. Look what happens when I switch to mortality. The colors have changed. I'm going to go back again to incidence. This is the incidence. It's something called age standardized incidence. So it takes into account the actual structure of the population, because different populations, different countries have different age structures. As you know, we are much older in North America than the average person in sub-Saharan Africa, for example. This is the incidence, and again, the mortality. And you can see here in North America, this is my native country, Canada, and the US where I live, we see that this has changed because breast cancer is not the #1 cause of cancer-related death among women, but indeed, this is lung cancer, right? It's a good news, bad news story because more women, of course, were smoking over time. Many years ago, there was a huge increase in women smoking, and now we're seeing, unfortunately, the impact of that, although that is starting to shift in North America. We also know that breast cancer treatment has become better, and early detection efforts have been very effective. Enough about that. Let's talk about cervical cancer. You can see here that much more of the map of sub-Saharan Africa has changed to orange, which means in 44 countries, mostly in sub-Saharan Africa, but also in Bangladesh here, and you can see in some parts of Latin America, cervical cancer is the #1 cause of cancer-related deaths among women. And indeed, it's the epitome of disparities. Almost 9 in 10 women who die of cervical cancer are living in a low-income or middle-income country. That's more than 350,000 women every year dying, 1 woman every 2 minutes. All of these are preventable. When we look at this by region, this is again from the IARC, WHO's Cancer Research Agency, we can see in terms of sheer numbers, most of the women dying of cervical cancer are living in Asia, and Asia broadly including all of Asia, South Asia, India, Bangladesh, etc., and Southeast and East Asia, including China. So yes, the population, of course, is much larger in Asia than elsewhere. But look how much the contribution is from Africa here. That's 81,000 women. Whereas in North America, the numbers are much smaller. But please don't mistake what I'm saying today. Any death from cervical cancer is a tragedy for the woman, of course, and for her family and her friends and her community at large. And in North America and other high-income countries like Canada and the US, we do see that the preponderance of women who die of cervical cancer are marginalized. They tend to be women who are poorer, who have lower social and economic status, women of color, women who have ability issues, and other minority communities. Same goes for women who are of migrant origin, who are refugees, etc. And so in 2018, the Director General of the World Health Organization called for all countries to take action to help end the suffering caused by cervical cancer. And he noted that cervical cancer strikes women in the prime of life. Not to say that anyone over 50 is not in their prime, myself included, but indeed, this is making a special effort to note that women tend to be of reproductive age and also women who are raising families, as well as participating in the health, in the workforce, also the health workforce, by the way, which is another topic that's important to note, especially in COVID times. But this is a preventable tragedy. Cervical cancer is one of the most preventable and treatable forms of cancer. And so he called for the elimination strategy, which goes by the phrase 90-70-90. To reach elimination efforts, we have to align our efforts and accelerate our efforts. And each country is expected to, aspirational goal, but certainly we want every country by 2030 to achieve 90% coverage of HPV vaccination of girls by 15 years of age. That's not to say that boys shouldn't be vaccinated, but girls really should be prioritized in many countries. Otherwise, the concern that WHO has expressed is that girls can be left behind. So at least 90% of coverage for girls and 70% coverage of the population at risk for screening, that's ages at least 35 to 45, with a high performance test. I'm going to describe what I mean by that in a moment. 90% of women who have an abnormal screening test should be able to achieve treatment of their precancerous lesions, sometimes called pre-cancer or pre-invasive cervical cancer. And 90% of women who have invasive cervical cancer should have effective treatment. And that includes systemic treatment, in some cases like chemotherapy. It definitely includes radiotherapy. Radiation therapy is a mainstay of treatment for invasive cervical cancer. And that's really unavailable in many settings, as I'll get to in a moment. This has been really well studied. The mortality impact of achieving the WHO's cervical cancer elimination targets. This was a comparative modeling analysis. You've heard a lot about modeling by epidemiologists now all over the world regarding COVID-19. The same applies to other health conditions, including cancer. And here, this was a pivotal seminal paper in 78 low-income and lower middle-income countries by Dr. Karen Canfell and her colleagues working with the World Health Organization on the elimination strategy, who said that, over the next century, successful implementation of this strategy would reduce cervical cancer mortality by almost 99%. and saved more than 62 million women's lives. Remarkable. These findings emphasize the importance of acting immediately on the three fronts: vaccination, screening, and treatment of pre-invasive and invasive cervical cancer. And in the next 10 years, we're supposed to get to that 1/3 reduction in premature mortality from non-communicable diseases as one of the health-related targets of the UN Sustainable Development Goals. So what will it take to reach these elimination targets in any country? This is from the WHO's Guide to Cervical Cancer Elimination. Actually, this predates it from the 2014 Manual for Cervical Cancer Prevention. That includes this very handy sort of chart for those of you who are not aware. This walks you through the natural history of cervical cancer. So unlike other cancers, including some which are preventable, we really understand the natural history of cervical cancer. Not 100%, but much more than we understand for breast cancer, for example. And here you can see around the age of 15 or whenever sexual debut occurs, first sexual experience, we have HPV infection, and this is so common. Most people who are sexually active will be exposed to HPV, including the cancer-causing or oncogenic subtypes of HPV during their lifetime, but the vast majority will not lead to cancer. And I should say that HPV is associated with 6 cancers, not just cervical cancer, but that's the focus today for this talk. And we see that this peaks and the precancers start much later. And so this is why we don't want to screen girls who are 15 years old, for example, because most immunocompetent people with a strong immune system will clear those infections, but some will go on to develop precancer. And if it's not detected and treated, unfortunately, cancer later on, 30s, 40s, 50s, 60s. So how do we close this gap? Well, we know about highly effective ways to screen for cervical cancer, including by Pap tests, but unfortunately, outside of the setting of high resource, high quality health infrastructure, it's really tough to scale up effective Pap-based screening and related treatment programs. It just hasn't worked out in so many countries, although in North America and Europe and Australia and many other settings, it's been very effective. And you can see dramatic decreases in the mortality from cervical cancer where such programs have been effective. So the World Health Organization and others started looking at visual inspection with acetic acid, that is literally vinegar, as a way to show abnormalities on the cervix during a gynecologic examination, and even to provide treatment right there and then in the same visit using freezing with cryotherapy that can include one of 2 gases, carbon dioxide or liquid nitrogen. But the problem is the tanks are heavy. It's hard to secure sometimes a consistent supply of the gases, and it's just been very difficult to scale. It hasn't been effective. There are lots of quality challenges, quality control challenges as well, with visual inspection with acetic acid, even in the hands of very well-trained health providers. For treatment, we now have something else called thermal ablation. We need to get the costs down for this, approved by WHO. And we also are still learning about how to best decide who should get treatment, even if it's based on HPV testing. Now, that's not HPV vaccination. That's actually looking at evidence of DNA from the human papillomavirus in the cervix, which is now the mainstay of primary screening in many settings, including here in the United States. But if you just treated everybody who was positive for HPV, especially in a setting like here in the US, where the risk of cervical cancer, the prevalence is actually quite low comparatively because we had decades of Pap tests, we would be over-treating a lot of women. And that's not a small issue. So we need to decide how best to triage those women in such settings, or whether indeed in other settings such as sub-Saharan Africa with high rates of co-infection with HIV, human immunodeficiency virus, that's a major risk factor for dying of cervical cancer. Those women tend to not have as good an immune system. In those settings, maybe HPV positive and treat is the way to go. But the problem is it's very expensive. It's not yet affordable in most settings, even though HPV testing is very cost effective, as I'll show in a moment. And so this is where we're at in much of the world. This is a major obstacle we have to overcome. We also need POC, which is point of care technology. So the HPV testing result can happen in real time while the woman's waiting in the waiting room, something like an hour. That would be fantastic if we could do that. There are certainly innovations on the way. There's a pipeline for innovation, but we haven't really seen it yet in a real world setting outside of a research situation, and certainly not in an affordable way. So what happens is the woman is tested. Hopefully she's notified. Maybe that can be done by cell phones, by text messaging, or otherwise. But the women who have an HPV positive test need to come back another time. And that's where we lose a lot of women. That's a really major cause of loss to follow-up. And ultimately, the woman will present later with advanced cervical cancer, even though she's had a test that showed she had a or likely to have a pre-cancer. And so that's another issue we need to work on through patient navigation and through, ideally, a point-of-care test. We have HPV self-sampling. This actually should be self-sampling, which means a woman can do the test herself in the privacy of her own home, for example, and at her convenience. And when we were asked, many researchers who work in different countries like I do are asked, well, maybe women won't want that. They're going to trust the healthcare provider to do it. In fact, that question's been asked in many countries now. And certainly some women will prefer that, but many, in fact, the majority, in every setting that I've seen anyway in the literature, women do prefer to do their own testing. And you can see how that could help close the gap, especially on women who are harder to reach, who may not want to have a gynecologic examination, who may be marginalized for many reasons, but they may prefer this. It hasn't been widely rolled out yet, but it absolutely should be. And again, this could be a game changer. And lastly, to mention an important emerging technology is something called visual assessment that's automated, or AVE, which was developed by the National Cancer Institute team of scientists led by Dr. Mark Schiffman and colleagues elsewhere. And they're using what's called machine learning, which is akin to artificial intelligence, to teach the computer to actually identify lesions that look like cervical pre-cancer. And this is in development, and hopefully, because of the pandemic, things have been delayed. But the idea is you add HPV-based testing, maybe through self-sampling, and then a health provider can use that algorithm in the future, once it's, of course, validated, and they might be able to have a clinical decision support right there at the bedside to tell them whether it's safe to treat that woman or she can go home and maybe get followed up another time. So HPV vaccination, cervical screening and treatment of precancers is already considered as very cost effective, which means less than $100 per year of life saved. And a cost-effective intervention, best buys by the WHO. You can look this up yourself. This was an addition to what was the Non-Communicable Diseases Prevention and Control Guide that existed for 2013 to 2020. When I was at the World Health Organization, many people were working on this new version of the best buys. So we have this information. This is not something that needs to be reinvented. The question is, how do we get there? How do we put this in the hands of people? And in fact, the WHO in 2016 and since then have been speaking about people-centered health services. This was actually a resolution at the World Health Assembly that was passed several years ago. That means putting people in communities, not the diseases, at the center of health systems and empowering people to take charge of their own health rather than being passive recipients of services. And evidence shows that health systems that are oriented around the needs of people and communities are not only more effective, but they cost less, and they improve health literacy and patient engagement and make the whole community more resilient and the system better prepared to respond to health crises. So you might think, gee, that would be a really important thing to be able to achieve now in the era of COVID. So we know what to do. The question is, how do we overcome that no-do gap? And this brings in the role of implementation research, which is the type of research that many of us who are lucky enough to have funding from the Prevent Cancer Foundation are involved in. I want to make a specific comment about COVID that I've alluded to. We published this. This is Dr. Karen Canfell, who I mentioned earlier, who works with the WHO on the elimination strategy for cervical cancer. She's at the University of Sydney, representing Cancer Council New South Wales in Australia. Dr. Sharon Kapambwe, who was at the Ministry of Health in Zambia, has now moved to the World Health Organization Afro Regional Office. And Dr. Partha Basu, who's the head of cancer screening at IARC. we wanted to show an effort to compare what's happening with the COVID technologies, et cetera, against what's been happening in cervical cancer. And yet cervical cancer has been so slow to gain momentum as a public health crisis, which it really is. So how can we frame this in terms of what's happening in COVID? And some people will say, just to remind you, I forget who first said it, vaccines don't save lives, vaccinations do. And so this is sort of the principle I'm getting at. So we talk about critical cancer treatment being available to less than 30% of women in low-income countries. And if access could be rapidly rolled out to most women, we could achieve premature mortality by a third, drop by a third in a decade. And if all three pillars are achieved, as we said earlier, something like 74 million cases could be prevented, 62 million women's lives could be saved over the course of the next century, right? But we need this extended research and development pipeline to generate effective and affordable options. And that's what I'm going to encourage those of you listening who are interested in cervical cancer or cancer prevention, of course, to consider where, we might put our resources to try to get from A to B and to develop and fund implementation research so we can really do this well and quickly. We need an effective global partnership. In this paper we published in Nature Cancer, we said public, private, and civil society organizations to transcend political boundaries and accelerate the scale-up of vaccination, development, and implementation of HPV tests that's as simple, quick, and affordable as a pregnancy test, and capacity building, frontline health workers for the treatment of invasive cervical cancer. And in this paper, we actually spoke of cervical cancer as akin to a pandemic, but one that's been hiding in plain sight for decades. And I'm going to end there, and I look forward to the moderated question and answer session at the end. Thank you so much for your attention.
Hello, my name is Dr. Daniel Peterwright. I'm a radiation oncologist in Rapid City, South Dakota. I'm the principal investigator of the Walking Forward Cancer Disparity Program, and it's my pleasure to be one of your speakers at the Prevent Cancer Foundation Prevent Cancer Dialogue. My disclosures are as follows. They all relate to supporting the Walking Forward staff and objectives to complete our research goals. In addition, I was past president of the American Brachytherapy Society. The objectives are discussing challenges of providing healthcare to tribal and rural communities in Western South Dakota, a brief summary on our 18-year results on our ongoing efforts to reduce cancer disparities through innovative technologies and patient navigation, challenges to lung cancer screening, which is obviously a focus of this entire meeting, how challenges were previously and continue to be addressed, and lessons learned. A bit of a geography lesson, where in the world is Rapid City, South Dakota? So we are located halfway between Boston and LA, right in the Black Hills area, where we serve the Native American communities that reside on Cheyenne River, Rosebud, and Pine Ridge. What does cancer in Native America look like? We published this a few years ago. There are high rates of high-risk health behaviors and comorbidities, leading to social stressors, low screening rates as a result of resources available, trust, the remoteness of this population, at times health literacy. American Indians, Alaskan Natives, and I'll use American Indian and Native American and Natives interchangeably, often present or do present with advanced stages of cancer diagnosis compared to other racial groups. They're less likely to undergo cancer-directed therapies after cancer diagnosis than non-Hispanic whites. In data from the Pine Ridge Indian Reservation, 51% live below poverty, and they have some of the lowest life expectancy rates in the U.S., 48 for males and 52 for females. Continuing on this, they were more likely to be admitted for non-elective procedures, more likely to undergo emergent procedures. Seranalysis demonstrates that they are less likely to undergo any cancer surgery at all compared to other racial groups in the U.S. There's a perception that cancer is a death sentence. They're less likely to receive chemotherapy and radiation for breast, colon, and prostate cancer. There are lower rates of hospice utilization compared to whites for those undergoing or dying of cancer. But poverty isn't the only issue. Poor cancer-related survival persists among this population, even when adjustments are made for the influence of poverty. The Northern Plains American Indians, where I live, have some of the highest cancer diagnosis and death rates in the United States, and they actually have the highest mortality rates from lung cancer. So this is a major issue. So Rapid City is located in western South Dakota. Again, these are the tribal communities that we serve. Geographic distance is an issue. Many parts of the U.S., there's a cancer center within 20 to 30 minutes of where patients live. For American Indians, the average distance they drive to Rapid City is 140 miles. So back in 1999, when I relocated here from the University of Wisconsin, I'm a native of South Dakota, I hit the road literally and figuratively to figure out what was potentially going on. This is one of the roads to Pine Ridge. So Walking Forward has at times been referred to as a community model for cancer control, from screening, navigation, clinical trial access, genomics, and palliation. The phases of Walking Forward, we break into periods of funding that are delineated by 5-year funding. So in phase 1 and 2 for about 10 years, our foundation was community education, screening, patient navigation, enrollment in clinical trials. For phase 3, we conducted a randomized control study on smoking cessation that I won't discuss today. We'll get into our current Ldct project, and we have another ROI or RO1 that's ongoing. It's a palliative care initiative. So initially when Walking Forward was developed, this was a competitive research application. A lot of this was behavioral research where we wanted to assess barriers to early cancer screening and detection, culturally appropriate community navigation, comprehensive patient navigation, recruitment to clinical trials, use of innovative radiation techniques such as IMRT, it's called intensity modulated radiation, in brachytherapy, in order to shorten the treatment duration from 6 to 7 weeks at times 1 day to 5 days. The primary hypothesis is that these interventions will lead to patients presenting with earlier stage of cancer. Conceptually, we know that these patients present with advanced stages of presentation. Could we go further upstream, so to speak, to figure out what are some of the health system factors that lead to patients presenting with such advanced stages of disease? So this was an extensive collaboration with the University of Wisconsin, the Mayo Clinic, and others over the last 20 years. Our 2 patient navigation programs, one is a community navigation program where they're called community research representatives. They're all American Indian. Their goal was to assess barriers to early cancer detection through a lot of social science surveys. They were out there promoting education, networking. Our cancer navigation program is that patients were diagnosed with cancer. We had LPNs or RNs that would help identify barriers during their cancer treatment with the goal to get them to their cancer treatment in a hopefully expeditious fashion. Patients underwent our patient navigation program. We were able to document an improvement in compliance. There are certain cancers such as head and neck cancer and cervical cancer that if you miss a week of treatment, their cure rates go down by as much as 7 to 10%. So we were able to demonstrate improved compliance with those patients that were navigated. Interestingly, 22% of these patients went on a clinical trial. This data isn't all being shown, but there was a reduction in treatment interruptions. The overall experience was enhanced. There was no change in trust towards a healthcare system. That's an issue it would take years to try to address, but all of our interventions were felt to be culturally competent. In the second phase of Walking Forward, we implemented a cancer screening coordinator where this person was an LPN or RN who worked on the IHS facilities, where now one can imagine we have our community navigators that are promoting education. They were then referred to our cancer screening coordinators for all screen detectable cancers to get them screened. And then if they were diagnosed with cancer, our LPN or RN navigators would take over to get them through the complexity of their cancer treatment. Example of some of our staff, this is down in Pine Ridge at a breast cancer screening event. This is an educational event on Rosebud. And this is another event that was in Rosebud. Note this is a very remote location. In fact, here there's no cell phone service. Word of mouth is often knocking on doors. And so our community staff have really been innovative of getting into these communities and trying to determine how we can best help them. For our screening initiatives over the years, as of November last year, we had coordinated 3,200 cancer screenings for the reservations that we serve. This doesn't include our lung cancer screening project. Briefly, in our 18-year results, we've recruited 10% of American Indians to clinical trials. 4,500 patients have actually enrolled in research studies. It's the highest in the nation for this population. Increased compliance with cancer treatment, identification of specific barriers to effective cancer screening and cancer care. When we get into that discussion, coordination of over 3,000 screenings. We were able to successfully complete a genetic study, completed a randomized control trial in smoking cessation. But a big part of this is establishing trust within the American Indian communities. Creation of this research infrastructure in the Community Cancer Center was a challenge in the beginning, but that's allowed us to continue through creation of partnerships both within our state and nationally to continue with our mission. And we currently are in the middle of a palliative care project. Clinical trials. Often these populations don't have access to innovative technologies. So I realize a lot of you in the audience may not be radiation oncologists or brachytherapists, but this is a very effective treatment. It's an hour procedure to put seeds in the prostate, high cure rates, takes care of the issue of geographic distance. We implemented a breast brachytherapy program to shorten radiation from 6 weeks to 1 week. And we see a lot of patients with locally advanced cervical cancer that benefit from MRI-guided brachytherapy that's very labor intensive. With my connections to the University of Wisconsin, we were able to implement this technology back in 2001. It's called Tomotherapy. It's a form of IMRT. This is a medicine man that came in and blessed the machine. So a lot of community networking. This was data that we looked at over 10 years ago, but when we look at the pre-walking forward era to the walking forward era, there's a trend that patients are presenting with earlier stages of disease. Now, it would be arrogant to say it's because of walking forward, because there's other programs, that are working in the community, but it's at least a suggestion that some of our interventions may have an impact. Smoking and lung cancer in South Dakota. Western South Dakota, where I live, has very high smoking rates, especially within the tribal communities. We have the highest lung cancer mortality rate in the nation. As a result of high smoking rates, a lack of access to screening, in clinically, I always ask my staff when we come up with new projects, we need to come up with a project that's clinically relevant. And so instead of seeing patients present at the cancer center with stage 3 or 4 lung cancer with bone, brain, or liver metastasis, the goal is that we hopefully can diagnose them earlier, in which the therapies are much more effective. The rationale nationally, or at least historically, has only been 2 to 4%, although that's improving. In our part of the state, there are 30,000 screen eligible South Dakotans, and in the western part, at least 14,000. At times, there's been a limited use of Ldcts by the primary care providers. Many high-risk individuals are unaware. And if you're going to do a screening test, one obviously has to ask the question, well, do you have any effective treatment options? And we do. Limited surgery or focused radiation using what's called stereotactic radiation can achieve cure rates to 90 to 95% for patients with stage 1 lung cancer. There's limited access to lung cancer screening in South Dakota due to our geographic remoteness. I won't read all these statistics, but this is a very large state with limited Ldct centers. So a few years ago, we submitted a research proposal to the NCI that wasn't funded. Fortunately, the Bristol Myers Squibb Foundation did fund this project, but the title is Increasing Lung Cancer Screening for High-Risk Smokers in a Frontier Population. The research question is, will provider and or individual level interventions increase the utilization of LDCTs, or low-dose computerized axial tomography, amongst high-risk smokers in Western South Dakota? The project goal is to increase lung cancer screening rates by educating primary care providers and their clinical staff, as well as community members in our part of the country. There are 3 aims to this research project. Aim 1 is screening awareness, to build on the previous research that we've conducted to improve provider and individual awareness of the impact of lung cancer screening. This included initial and follow-up surveys. Aim 2 is to evaluate the efficacy of 2 interventions with the primary care providers and community members to, again, increase awareness of the screening test. But really the main measure was to document the number of LDCTs completed. For Aim 3, which will happen this fall, we'll have a policy symposium on lung health forum in partnership with Dr. Betty Jacobs at the Georgetown University, and we'll include many regional and local speakers as well as international speakers on this topic. We want to be able to develop a sustainable, evidence-based, culturally and regionally appropriate practice with policy recommendations. So the study design is a 2x2 study design to evaluate 135 providers and individual interventions. The individual or community interventions is 1,000. Both interventions include an education and an introduction to the online resource. And again, the metric will be to increase the rate of LDCTs. This is the first project that we have that will include both natives and non-natives. However, the study is being enriched with the American Indian population since they have a much higher smoking rate. So this is the challenge. Within the Black Hills area here, or the population base that Rapid City serves is about 350,000. There's a number of LDCT sites within our region, but as we get further out into the state, it's very limited, especially in the reservations in this part of the state. So because I've been here for 21 years, I do a lot of community outreach, both as a practicing oncologist and as PI of the Walking Forward program. I almost know the majority of the primary care providers. I know the radiologists. They've been very receptive to working with us. And what our staff does is every 6 months is we update the data and what the increase in LDCT utilization rates are. Right now, we don't have the data because it's not quite mature. But as far as the number of sessions that we performed, we started in September 2018. Again, the goal is to provide a CME talk for 135 primary care providers. We're getting there with 95. We're close to 100 now. The community workshops, we're well over 500 at this point. And then to date, we've had 100 LDCT referrals with 81 completed. So we're certainly making progress. These are the results of the baseline LDCT utilization within our catchment area. Year 1, year 2, you can see there's an excellent trend. We continue, and then all of a sudden COVID hits. And so, as I'm sure all of you are aware, once COVID hit about a year ago, especially in the cancer screening world, cancer screenings for all screen detectable cancers basically went to zero. And so we certainly saw that because patients weren't going to come in for screening events when we had more pressing issues going on. So certainly there was a negative impact with COVID. What are some of the challenges? Indian Health Service is currently not covering the costs nor providing LDCTs. This is soon to change in Rosebud in that they're going to start providing LDCTs. Part of this is that IHS is underfunded. It tends to be life and limb policy. And anytime one conducts research in these communities, you have to go in front of the tribal health boards, their councils, and they astutely picked up 3 years ago when I went down to Pine Ridge that, well, you're going to be out here, Dr. Peterwright, advocating for LDCTs, and we don't provide them. I said, well, that's a good point. So we were fortunate in that we received foundation money from a group called the Irving A. Hounson Memorial Foundation for $152,000 that will allow us to screen 400 American Indians at no cost. So fortunately, that worked out. Our education sessions, our staff are terrific. They had to be innovative. There was a lot of virtual discussions. There was some events being held outside, obviously being respectful of what the current policies are for social distancing. I love this picture here. This was taken over a year ago. This is by the Wounded Knee Massacre, about 5 minutes from that location. And this is one of our staff, meaning a couple who participated in our program for the 6-month survey. So where we have the geographic remoteness, they had to walk a mile down this road. Our staff met them here, and they're signing a consent form on the hood of a truck. So staff, again, are very innovative and well-connected in the communities. Our last theme on this is going to be our policy symposium that we're looking forward to. And we're hoping that we'll be able to change IHS policy to provide these services. And we're working with the radiologists and the primary care providers to help them strategize how this can be successfully accomplished. Last year at this conference, one of the speakers was Dr. Pasquinelli. She talked about this CREST analysis. Now, it turns out that the current screening guidelines for lung cancer in the African Americans in Chicago should be different based on the analysis that they ran. And so when I heard Dr. Pasquinelli's presentation, I connected with her quickly and their group is going to be performing a statistical analysis on the American Indian population. And so the previous screening guidelines of 50 or 55 to 77 or 80, a 30-pack year smoking history, we know that's going to be much different in this population. A lot of these patients have a 30-year pack year smoking history by the time they're in their early 40s. So by the time we have our healthcare symposium, we should have some updated data. Pathways of sustainability. This is community-based participatory research. Patient navigation is a foundation of walking forward. There's constant communication with our staff and community. We're listening to community signals and adapting and changing over time. We have a community presence to nurture this ongoing trust. Walking Forward is a known entity. Other programs approach us to see if they can potentially work with our program to implement new research ideas. We collaborate with everybody. We have extensive collaborations within South Dakota, within academic centers throughout the U.S., political partners, and a number of PhDs, MDs, and basically anybody that would like to work with us. This is implementation science. This takes a while to get this off the ground. This takes absolute persistence. I would say the motivation of our staff is to help the underserved, and the end result is we've achieved a program that's gone from 5 years to 22 years of funding. This does take patience. It requires that the principal investigator is part of the community or the region. I have dedicated research time to work on this at least 1 day a week. It's usually about 10 to 15 hours a week. The challenges of the workload of primary care providers. An interesting statistic, Indian Health Service is underfunded. The per capita funding for IHS in 2017 per patient was $3,851. For the general population, it's over $10,000. Future funding for our Ldct program. Our current goal is to extend the healthcare prevention, to extend our lung health prevention research to enable the momentum to continue. This has taken a long time to get this off the ground. We've made significant progress despite COVID. Funding for our community staff ends this August. We'll be looking at potentially VMS to continue some of the funding, other foundations. The annual budget to continue our program is about $150,000. Our vision is to improve the quality of life for American Indian cancer patients from early detection, successful treatment, and survivorship, including end-of-life care. Our mission is this has been and will continue to be accomplished through access to screening, state-of-the-art cancer treatments and clinical trials, and comprehensive patient navigation. And we're currently expanding into the entire western part of the state as far as not only the natives, but the non-natives. This is our Walking Forward staff. It's an extremely dedicated team, wonderful individuals. And I again want to thank you for inviting me to be one of your speakers for the Prevent Cancer Foundation. Thank you.
Hi, my name is Gloria Coronado. I'm an epidemiologist at Kaiser Permanente Center for Health Research. The title of my talk is Improving Follow-up of Positive Stool-Based Tests with Timely Colonoscopies in Community Health Centers. So today I want to tell you about a program to help patients who need a colonoscopy get one. This is important because millions of people each year get an easy at-home fecal test to find early signs of colorectal cancer. Yet many of those patients forego the important next step, which is a follow-up colonoscopy. These patients have about a 1 in 11 chance of having colorectal cancer. My research shows that we can use the existing data in the electronic health record to identify patients who are likely to forgo colonoscopy. By providing assistance and support to these patients, we can improve participation in colonoscopy and save lives from the second leading cause of cancer death in the United States. By way of disclaimer, in the past year, I've served as a scientific advisor for Exact Sciences and Guardant Health. These relationships do not influence my talk today. So I want to share with you some background information on colorectal cancer screening, the importance of timely colonoscopy follow-up of positive stool-based tests. Then I'll talk about an innovative data-driven solution that we've put in place as part of the PRECISE study. Then I'll offer some conclusions and next steps. Colorectal cancer is the second leading cause of cancer death in the United States. About 150,000 people get colorectal cancer each year, and nearly 50,000 people die from the disease. Because colorectal cancer grows over the course of 10 to 20 years, it can be detected at different stages. And you'll note from this image that in stage 3, the cancer cells have breached the wall of the colon and now appear in the surrounding lymph nodes. In stage 4, also known as metastatic cancer, the cancer cells have now spread to other organs of the body. Each stage of colorectal cancer is associated with a different probability of surviving 5 years. For individuals that are diagnosed with early stage colorectal cancer, their chance of surviving 5 years is 90%, and many of them will survive well beyond 5 years. For individuals who are diagnosed with advanced stage colorectal cancer, on the other hand, where the cancer is spread to other organs of the body, these patients have only a 1 in 10 chance of surviving 5 years. The good news is that recommended screening could prevent at least 60% of the deaths from colorectal cancer. But the problem is that screening rates are low. Nationally, based on data from the Behavioral Risk Factor Surveillance System from 2018, the rates of colorectal cancer are only 69% nationally. And in certain settings, like in federally qualified health centers, those rates are even lower. The rates from 2018 show a rate of colorectal cancer screening of 44%, and both of these rates are well below the national goal set by the National Colorectal Cancer Roundtable of 80%. The good news is that rates of colorectal cancer screening have been increasing in federally qualified health centers. You'll see in this diagram that in 2012, the rate was 30%, and over time, that rate has increased to 44% by the year 2018. There's great anticipation that in the year 2020, the rates have dropped significantly due to care suspensions that were put in place as a result of COVID-19. There are a variety of recommended ways to screen for colorectal cancer. An easy at-home option is the fecal test, also known as the fecal immunochemical test, or FIT. And this test looks for hidden blood in the stool, and it can be done without any dietary or medication restrictions. Another test is a colonoscopy, where a doctor inserts a tube in the rectum to view the entire colon and remove any early growths or polyps that he or she finds. And other tests that are recommended include the sigmoidoscopy, the CT colonography, which is an X-ray of the colon, or multi-targeted stool DNA, also known as FIT DNA. The current U.S. Preventive Services Task Force recommends screening for average risk adults beginning at age 50 and continuing to age 75. New draft guidelines that were issued in 2020 dropped the initiation age to age 45 rather than 50, and these recommendations align with recommendations issued by the American Cancer Society in 2018. This change, the drop in the age of initiation of 45, will result in an additional 22 million adults who are due for colorectal cancer screening. So the problem is that for those adults who begin screening by using stool-based testing, colorectal cancer screening is a two-step screening process. It begins with fecal testing and ends with a colonoscopy. And there are millions of adults who complete fecal testing each year, and yet not all of these adults who have an abnormal test result will go on to get the colonoscopy procedure. And for these patients, the benefit of fecal testing is nullified. And for the health systems who have put in effort to promote colorectal cancer screening using stool-based testing, those efforts are also nullified. And this matters because as many as 1 in 11 of these patients with an abnormal FIT test result will be found to have colorectal cancer. So they represent a high-risk population. And we know that delays in getting a colonoscopy procedure after an abnormal FIT can result in increased likelihood of getting colorectal cancer by 31%. They're also 7 times more likely to die from colorectal cancer and 2 times more likely to be diagnosed with an advanced stage of colorectal cancer. In safety net practices or community health centers, the rates of colonoscopy following the abnormal FIT test result are unacceptably low. The published literature shows that those rates range from 37 to 53%. The previous literature shows promise for patient navigation in addressing the barriers that patients face in getting a follow-up colonoscopy. Bev Green in 2014 published a study at a group health cooperative showing an 11 percentage point boost in follow-up colonoscopy rates following a patient navigation program. Reich in 2012 reported a 21% boost in follow-up colonoscopy among patients with an abnormal FIT test result in a randomized trial. And 2 additional observational studies showed promise for this approach. But one of the biggest challenges that health systems face is really figuring out who to deliver patient navigation to. And there's a variety of health systems that have tried different approaches. For example, some health systems will deliver patient navigation to those patients who screen abnormal on FIT testing. And this approach makes a lot of sense because, as I mentioned earlier, these patients have up to a 1 in 11 chance of having colorectal cancer. And so making sure that these patients get that follow-up procedure is really important. Other programs might focus on those patients who've never had a colonoscopy procedure. And this approach also makes a lot of sense because those patients who have never been through the process may face additional obstacles and be unaware of the steps that they need to take to complete the procedure. Other programs might focus on patients who have no upcoming colonoscopy appointment, but I think we can all agree that patients who are able to make an appointment still may face other barriers in terms of completing the colonoscopy prep or making it to the procedure. Other programs might target their patient navigation resources to patients who simply haven't obtained a colonoscopy after a certain number of months, like 6 months. However, the problem with this approach is that it's difficult to communicate the urgency of obtaining the procedure. And oftentimes after 6 months, it's more difficult to reach patients, as patients in community health centers in particular often change their address or phone number quite frequently. Other programs rely on provider referral, but I think we can all agree that providers are not always consistent in referring patients to needed services, and providers simply may not know which patients may benefit from patient navigation and which ones will not. So what we're proposing today is using the available data in the electronic health record to identify those patients who have a low probability of getting a colonoscopy procedure and directing patient navigation resources to those patients. So if you take a group of patients who all have a positive FIT test result, and if there was some way that you could tell which patients might benefit from patient navigation, like they all wore a red suit, for example, then your job would be easy. You would simply deliver patient navigation services to those patients. But unfortunately, we don't always know. And what we're proposing is that standard navigation programs have typically been offered to all patients, irrespective of their likelihood or probability of getting the procedure on their own. And so what we're proposing is really the funnel on the right, which is assessing a patient's adherence probability and delivering navigation to the patients who have a low or moderate probability of obtaining the procedure on their own. So our study is called Predicting and Addressing Colonoscopy Non-Adherence in Community Settings, also known as PRECISE. PRECISE is a partnership between Kaiser Permanente Center for Health Research and CMAR Community Health Centers. It's a 2-phase patient randomized trial of patient navigation versus usual care. Our plan is to enroll 1,200 patients across 28 CMAR clinics over the course of a 5-year R01 study that's funded by the National Cancer Institute. So our partnering health center, CMAR Community Health Centers, serves about 300,000 patients in 32 primary care clinics in Western Washington. Their patient population is about 40% Latino, which represents the same percentage that we see in federally qualified health centers across the US. CMAR operates a centralized mailed FIT outreach program that delivers fecal tests to patients' homes each year. The program produces about 700 patients who have an abnormal FIT test result each year, and the follow-up colonoscopy rate is only 43%. So if we look at the follow-up colonoscopy completion rate across time, we see that at 90 days, about 23% of patients with an abnormal FIT test result obtain a follow-up colonoscopy. And this is the timing of a benchmark set by the Prosper Collaborative of the National Cancer Institute. If you extend that interval to 360 days or a full year, you see that that rate reaches 43%. There are a variety of steps in obtaining the follow-up colonoscopy. Patients start with an abnormal FIT test result. They're referred to gastroenterology. They attend a pre-procedure visit, and they obtain the colonoscopy itself. And what we see in CMAR data is that with an initial group of 715 patients who have an abnormal FIT test result, about 90% of them are referred to gastroenterology. However, only 52% of them attend that pre-procedure visit, and 43%, as I mentioned previously, complete the colonoscopy procedure. So what we see is a tremendous drop-off between the referral to gastroenterology that occurs in primary care and the participation in the pre-procedure visit that happens at the specialty care site. Our risk prediction model uses available data in the electronic health record to identify patients' probability of obtaining a follow-up colonoscopy after an abnormal FIT test result. And what we see in the figure on the right is good discrimination across patients' probability, with the bar at the top reflecting patients who have a high probability of completing the colonoscopy procedure. The lines that are labeled B representing patients who have a moderate probability, and the lines labeled C representing those patients who have the lowest probability of completing the procedure on their own. The patient navigation program that we're using was developed by Dr. Lynn Butterly from New Hampshire. The program is a timed 6-topic telephonic patient navigation program that was delivered by a registered nurse who spent about 2 hours per patient delivering navigation. And the initial findings from the program were outstanding. It showed that patients who were navigated were 11 times more likely to complete a colonoscopy than non-navigated patients. Navigated patients were 40 times less likely to miss the colonoscopy appointment, and they were 6 times more likely to have adequate bowel prep than non-navigated patients. And here we see the actual numbers from the program that showed that the rate of colonoscopy completion among navigated patients was 97%. The rate of adequate bowel preparation was 99%. And the program nearly eliminated missed appointments or cancellations that occurred within 24 hours of the appointment. And as we can see from this table, all of the navigated patients got the results communicated directly to them, and their providers also received the results. So by conclusion, risk prediction modeling shows promise for selecting patients for patient navigation based on who has the lowest or lower moderate probability of getting the procedure and may benefit most from that extra assistance. Upcoming changes to the U.S. Preventive Services Task Force guidelines, as well as the care suspensions that occurred as a result of COVID, really underscore the need for precision tools and having the ability to direct resources to the patients who may benefit the most. And so another way of understanding this program is that if your job is to give out hats to people who need hats, you might start with some people having hats and other people not having hats. And so one option you could take is to give hats to everybody, in which case some people would have 1 hat and other people would have 2 hats. Another approach, and some programs I think do this, where they give hats to those patients who already have a hat because it's easier to serve these patients, or there may be limited hours of operation and those that don't have hats may not be able to come in for a hat. But what we want to achieve with Precise is really offer patient navigation services or offer a hat to those patients that don't have one so that everybody has a hat. So I want to acknowledge my wonderful team at the Center for Health Research at Kaiser Permanente, our partners at CMAR Community Health Centers, and of course our funders at the National Cancer Institute, the Center for Health Research leadership team, as well as the Martin Favorite Foundation. And if you haven't checked out our website, please do. We're at mailedfit.org. There's lots of material. Really happy to have you use it. Thank you so much.
We're all back in the group now. Let me also say that I neglected to mention I did not have any conflict of interest related to this session to announce at the beginning. So just let me remind everybody right now, again, thank the speakers in case I wasn't on when I did that. But these outstanding presentations, you can ask questions and comment and make comments by clicking in the Q&A icon at the bottom right of your screen. These questions are going to be moderated and we will do our very best to do as many of them as we can. In the meantime, we want to ask something about you. There would be a poll in the bottom right of your screen. Please answer the question and you can follow along and see the results as they roll in.
Everyone's speechless.
I think so. And I'm going to go ahead and, given how many questions I know we're going to have, we include mine, I'm going to go ahead and get started on these. Gloria, the first question is for you. Would you quickly explain the difference between FOBT and FIT? This comes up a lot, and I think you can do this very quickly.
Happy to. So an FOBT test is generally a 3-sample test that detects blood in the stool, but it's not specific to human blood. Typically, FOBT tests do have dietary and medication restrictions. So there's a new brand of stool-based tests that came out probably about a decade ago called the FIT test, and these are specific to human blood. They typically are a single sample, and they don't require any medication or dietary restrictions.
Thank you, Gloria. We have the results of the polls are in. 45% of you say you are not involved in implementing cancer screening. 28% say yes, somewhat, and 29% say yes, you are. So that is close to about, inching up to 2/3 of you are somehow involved in implementing cancer screening. This next question is for Dan. Is the fall meeting to review lung cancer screening study results planned to be virtual? Will it be open to the general public? I think you piqued people's interest in describing that meeting, and perhaps many are wondering if they can attend.
So it's going to be an in-person meeting. I'm hoping we can set it up virtually as well, just so we don't have a ton of resources. All the speakers agreed to come in. Our state, for good or bad, is a little more lackadaisical about the social distancing. That's not necessarily good, but I think it'll be a safe meeting. And right now it's in person, but if there's a way to expand this to a virtual platform, we definitely will.
Okay. I have a question for Ophira. This is such an ambitious goal. It's really an exciting goal to eliminate cervical cancer. When I was at the CDC, before the breast and cervical cancer program was established, Jim Mason, we were hot after having eliminated smallpox, and he said, can we do this with cervical cancer? And all of us who were program people around the edge thought no, and all the people around the table said, of course we can. We know that there are challenges, but this is really so ambitious. And what you described were a lot of transformative technologies, I think, that will address many of the challenges we've had to date. At the same time, as you put it, and I love this expression, know to do, between knowing and doing. We have technologies that work now, and in particular, vaccines could accomplish so much going forward. What can WHO and others do, or are they doing, to maybe provide country by country, region by region, practical blueprints that say, the starting gun is gone off. Now it's time to get moving. Can you just say a few words about how we get to this ambitious goal in 10 years?
Sure, I'll try to be brief and not take 10 years. It's a great question, and as I said, and I apologize, I'm not sure who I'm quoting with the vaccinations save lives. You need the vaccines, but vaccinations save lives. It's the same principle. How do you implement, right? And countries, especially low resource areas where they have clearly competing health priorities long before the pandemic, right? They only had so much to go around, and there's the emphasis on trying to get more into the health system, but then you have to cut the pie. There are very specific guidelines. In fact, there's a brand new, a few months ago, almost hot off the presses guideline at WHO, and I encourage people to look at the WHO website. You can search for cervical cancer and find all of these resources, step by step, to implement HPV-based screening. And the same holds for other health conditions and other aspects of cervical cancer prevention and control. There's also technical support that you can ask for countries that most countries belong to, member states to the World Health Organization. And technical support can come also from other partners like the National Cancer Institute, the NCI in the US, and the International Cancer Control Partnership, for which I'm on the steering committee. We provide, on a volunteer basis, technical support to help even use those tools to strategize how to make these changes into your health system in a pragmatic way.
Great, thank you. Gloria, we have a question as to the, people are wondering why the appointments to the gastroenterologist were missed at such a high rate. And one question is, were patients given a clear explanation for what that appointment was for? And what barriers do you think prevent them from going? Is it additional cost? Is it a health literacy issue? Is there confusion about the purpose?
Yeah, really good question. We looked at the notes in the chart for all of these patients, and we compiled kind of what we found from the notes in the chart. So this data isn't talking to patients, which I think would actually give us a richer information. But just based on the notes in the chart, we see that a lot of patients just aren't reachable. They have changed their number, they've moved. And in other cases, the patients do face barriers in terms of insurance. And sometimes their providers are saying, why don't you just do a second test rather than getting that colonoscopy? And so I think that we do see that the issues kind of span the gamut. And so but what we have done in a recent analysis is to try to determine what the barriers are at each of those stages, because there's a little bit of drop off with some patients not getting referred. And what we found is that most of the time they're not referred for legitimate reasons, but the really important one is between the primary care and the specialty care. So there's a lot of work to be done in this space for sure.
Yeah, we've seen that in the literature. Thank you, Gloria. Dan, this is a question. What is the ratio of lung cancer screening eligible persons to low-dose CT facilities participating in walking forward? I think the question basically means what are the access challenges right now in terms of the available facilities in the region and the eligible number of walking forward patients?
I would say in the Black Hills area, where most of the primary care providers are within the same healthcare system, and we've reached out to all of them. In fact, within our electronic medical record called EPIC, we actually have a walking forward Ldct tab, so that way they can bill our program if those patients don't have money. It's an ongoing challenge for Pine Ridge, where we do have funding to pay for their transportation up here, pay for the cost of the Ldct. Those communities were on a travel ban for a long time. There was actually security when you went down to the reservations. I mean, I haven't been able to go down for 6 months, but I think I can go down now. But I think there's been a lot of fear for patients coming up to this area to get their Ldct. I do think it's getting better. But despite having a program intact where we can cover the costs and cover the logistics, and we have we have a brief referral that the primary care docs can fill out, there's still challenges. So at times it's maddening. And one of our best sources of communication has been on a local radio station in Pine Ridge called Keeley Radio. We go down there, we just promote it to everybody down there. They go knock on the doors, it's literally and figuratively of their primary care provider saying, we want an LDCT referral. We heard about it on the radio today. So we're getting there, but I wish it were happening more quickly.
Yeah. Is there any potential for a mobile van? You know, one of the things that when we map out the availability of these facilities and these resources, we understand that these distances take on different meaning depending on where you live. I mean, I think people out in the West are used to longer distances, but the distances you described are daunting. Is there any potential for a mobile van?
Yeah, if anybody wants to donate one, that would be awesome. I mean, but that's
Okay.
a flippant answer. But no, we've looked at that, and within the Vera Healthcare network that we work with, they've had some mobile units, but there can be challenges with that because I mean, it's not rocket science to get an LDCT, but they have to the format for it compared to a regular CT has to be reformatted. And I mean, I'd love to see that happen because we've done that with mobile screening, mobile mammography units. So the short answer is yes. We just would like to put that together somehow. That would be much more palatable.
And if I could, can I ask you one last question that I think is on this very topic? There's a sizable, and there will be a larger proportion of women who are going to be eligible for mammography and also eligible for lung cancer screening. And given those distances, is there any potential or consideration of coordinating those exams?
I would say yes. I mean, our community staff does a terrific job networking with people in their local community. So in Katrina Armstrong, who's chair at MGH, she has a program in Rosebud, and so we've networked with them because they try to coordinate a lot of these screenings. But yeah, that would make a lot of sense.
Yeah, and we have a study about to get started doing this as well. Ophira, quick question. I'm not sure that there's an answer yet in the U.S. Maybe there is in Europe about the names of some of the home HPV tests.
Well, if you're thinking brand names, I to be honest, I off top of my head can't even think of one. We think of them as the concept of the self-collection, and I don't think it's the right venue to talk about specific brands, but I'm happy to discuss offline.
Yeah. Well, we're all anxious for them to be available. And one of my colleagues in Sweden, they were very anxious to try to use these tests during the pandemic, but they couldn't get any swabs, you know?
Right. So I can say that self-sampling has already been shown to be highly effective in very low resource settings. And a lot of the formative work was done by Dr. Silvina Arossi, who some of you might know has worked with the International Agency for Research on Cancer and has US NCI funding now in Argentina. Elsewhere, it's been done in India and all throughout the world, actually, but in small pilot studies. And we really need to start scaling this.
Yeah. Gloria, but you know, we've been looking at these really discouraging numbers of follow-up of positive stool tests for a long time. And I think what you've demonstrated is very sensible, right? Because you've got this big disconnect because there's no system. And you almost get a sense that everybody's thinking it's somebody else's responsibility to do the right thing after you have a positive test. And I'm just wondering, the other daunting thing has been you've demonstrated how effective navigation is and how necessary it is. So I think that the strategy that you're pursuing now is really very, very smart because, you know, you get this question, does everybody need navigation? And the answer is clearly no. Do you think this has a potential to break this logjam of us not funding an intervention that has been proven to be so amazingly effective and delivering services to people who otherwise aren't going to get them?
Such a great question. And, you know, I think that the challenge is really an implementation challenge, as you mentioned, right? Because there's not a single, you know, clinic administrator out there that won't say patient navigation is what we need. So you don't need to prove from a scientific perspective that patient navigation works. You just need to address the implementation challenges. in getting people to adopt it. And so one of the first implementation challenges that we encountered was just that, like, we don't know how to get started because who do we give navigation to? We're so overwhelmed. There's too many people in our system or what have you. And so this is a strategy to say, we can help you make that decision using the data that you already have. And so I would love to see this scaled up because I think what we're doing is really sensible and a big part of my push. And I think there's a question about what we would teach, new students these days. And I think that it's really about the fact that you can address health disparities and still meet the business needs of your health systems, because oftentimes people think that they're at odds and they don't have to be at odds. You can do both. So that's a big piece of what I like to demonstrate in the research that I do.
Is there, let me just follow up this one more thing. Is there any plan, or is anybody likely to be, as you are proceeding, doing the economic and policy research to be able to make the case that this is actually a good buy?
It's such a good question to think about costs from an efficiency perspective, right? Like, you're saving money by not having to deliver navigation to people that don't need it. We had included a cost component on our initial proposal, but we've ended up having to scale it back just because we got an initial cut. And then with COVID, we've had really a lot of trouble getting enough people enrolled. Because the fit testing rates went way down at our clinic. They had about 700 positive fits in 2018, and they were down to like 258 in 2020. So fit testing rates went way down, and so it's resulted in us having issues around recruiting. And so we've had to redirect our own resources to really kind of focusing on our main priorities. But it's something that we would love to do, or perhaps could be done as the next step in this research.
Thank you. It's very exciting. It sounds to me like also something for the roundtable to be paying attention to, because we had done a links of care, which was very successful. But again, it's like all these things, it's very labor intensive. And if you can just embed these assets into the clinic, like navigation for those who need it, it's just the smartest way to go. Mm-hmm. Time for two last questions. Ophira, quick one for you. Can you just quickly describe the continuing barriers to vaccination in these low-income countries and whether we're making any progress against them for HPV?
Mm-hmm. Yeah, great question. And I'm going to start just by coming back to that phrase, because I think somebody else wanted me to clarify. When I said vaccines don't save lives, vaccinations do. Of course, vaccines save lives, but they're only going to save lives if they get in the arms of the people who need them. That's the implementation challenge right there. And we're seeing this with COVID-19 vaccines as well. In the case of HPV vaccination, in fact, most countries where the risks are the highest, such as in sub-Saharan Africa, where it's a number one cancer-related mortality in women, people are clamoring for HPV vaccines now. The countries have been very effective in mobilizing interest and advocacy efforts and what have you. And it's really a matter of funding and getting it on the radar once it's in the national immunization programs. And that's another role that WHO helps support along with other civil society organizations. So they're waiting and ready. And some countries like Rwanda have been tremendously effective. Let's see how they've done that, right? And learn from it.
Well, it's very exciting to see the numbers when your population has an increasing prevalence of boys and girls who've been vaccinated, or just girls. And they start to get at the age we're just not seeing the rates of abnormalities that we would expect. So
it's incredible. It's a game changer.
Daniel, one of the biggest challenges that people speak to with respect to low-dose CT screening for lung cancer is that subset of the population that is going to have a nodule detected on screening and are going to need to come back in 6 months. How well are you managing to get these people back in the program?
So if anyone on study, if they go through our program and they undergo an Ldct, I get the results right away. We call them. There's 2 interventional radiologists and a few other folks that look at it to assess there's certain criteria of how they should. A lot of these patients can just have a follow-up CT scan 6 months later. But the last thing we wanted to do is get these Ldct scans performed, and then we don't find the results out. So we have a process in place. So that won't happen.
That's good.
We don't have a large pulmonary tumor board. It's just me, the interventional radiologist, and the other radiologists. So we just get it done. But I suppose it could be a little more sophisticated. But I think we've done a pretty good job in following up on patients and making certain that nothing's being missed.
Yeah, and something slightly off topic from your talk, but I'm also wondering, for those patients who are diagnosed with lung cancer, are you finding that these patients are, and if it's an advanced lung cancer, are they able to get comprehensive biomarker testing to determine whether or not?
Yeah, I mean, a lot of these patients are going to be stage 1, and many of them will have limited pulmonary function, so SBRT is a better option for them, but that's run through our tumor board about which way to go with their management.
Okay. I see that we are perilously close to our wrap-up time. Let me thank the audience for their attention, and let me especially thank the speakers for 3 outstanding presentations. I think you all can see how they are interrelated in the extent that they have focused on how do we take knowledge that we have and make sure that it gets applied. David Starr Jordan, we all remember this famous saying that wisdom is knowing what to do, virtue is doing it. And I think too often we are pursuing the next best thing, thinking it's going to be here any day, and neglecting just basic things that we know how to do. It could do well if we just made a point of doing so. I want to congratulate you all for the important work that you're doing, and hope that it's really all of our jobs to make sure that the results of the studies find a way to be applied in their settings at the first opportunity. So thank you very much. And I think we'll say bye.